Hello, and thank you for joining us today for our 2025 Medicare Town Hall, where we'll discuss upcoming changes as well as questions you may have about your Medicare coverage in relation to managing your psoriasis and/or your psoriatic arthritis. My name is Bev Bromfield, Patient Education Programs Manager here at MPF. A couple housekeeping needs before we start. Please keep your camera off and your mic on mute unless you would like to ask a question of our panel members. While we receive questions prior to today, we will also take questions live for our panel members. Please raise your hand to ask a question. Questions can also be placed in the chat box. Now, I'd like to take a moment to acknowledge and thank our sponsors, Sun Pharma and Novartis, for their support of today's town hall discussion and other recent Medicare education programs. Thank you. Before we start, a few words about what the National Psoriasis Foundation does. At the heart of all we do is our mission to drive efforts to cure psoriatic disease and improve the lives of those affected. We accomplish our mission by funding research with over $30 million awarded in grants and fellowships and collaborative and transformational research initiatives. New grant fellowship recipients were awarded in July. The MPF also offers education for those living with psoriatic disease and encourages all to become involved with our mission. Learn more about our research and education and how you can become involved by viewing the links listed on this slide. It's my pleasure to introduce you to our guest moderator for today's town hall discussion, Jason Harris, who is the Vice President of Government Relations and Advocacy here at NPF. Jason joined NPF in 2022 with over a decade of experience leading efforts to address health policy that benefit those with chronic health conditions, from those with psoriasis and previously with the Lupus Foundation of America, the National Health Council, and the ALS Association. Thank you, Jason, for leading our discussion today.
Thanks, Bev. And we're really fortunate to have two amazing speakers and guest panelists with us today. The first, David Kline, who goes by Dave, but he is the Prescription Drug Plan Growth Leader and Senior Business Advisor to the Medicare Chief Growth Officer at CIGNA Healthcare. At CIGNA, he relaunched the prescription drug plan business and provides strategic insight and guidance on the full Medicare product portfolio. Prior to CIGNA, Dave was leading transformational change in the development of new services, broker tools, and solutions at CVS within its Medicare units. This is one of my favorite parts of his bio right here, but the broker community views Part D Dave as a leading Medicare PDP knowledge source, thought leader, and engaging trainer who has a knack for taking complex issues and making them easier to understand. So we'll look forward to him taking some of these complex issues in a little bit and making them easier for all of us to understand. Our second panelist is Dr. George Hahn, who's a dermatologist and an associate professor at the Icahn School of Medicine at Mount Sinai. He is the president of the Dermatologic Society of Greater New York, a member of the medical board of the National Psoriasis Foundation, which we are very grateful to have him on that. Dr. Hahn, a counselor of the International Psoriasis Council, an associate of the International Eczema Council, and also serves as vice chair of the Council on Practice Management of the American Academy of Dermatology. So it's my pleasure to welcome both Dave and Dr. Hahn as our panel members today. I think they're going to be able to share some really amazing insight with all of you as attendees. Before we do that, I just want to go over just kind of some background on what we're going to get into today, as well as provide some context on the Medicare program in general, and just take a look so we all have a little bit of a level set. So there are various components to Medicare, as you can see on the slide. Part A really deals with anything related to the hospital and the services you may get there. Part B is, it says medical service, but really think of that as things that happen at your physician's office. In some cases, we know folks go in to get infusions at a medical office, and that would be Part B. Part C is what's known as Medicare Advantage. So that's in many ways kind of a bundled service that includes A, B, and in most cases does have Part D, which is a prescription drug plan, and we can get into a little bit more there. And I know we'll get into more resources later, but we had a great webinar, 101 webinar with Jason Mackey that'll be available that really goes into some of the specifics on these. So if you haven't seen that, I encourage you to check it out. And then Part D, which is going to be the bulk of our conversation today, which is prescription drugs. And the purpose of this entire education series in this town hall is to provide a platform and an education program on some of the new changes that have occurred in Part D. What we've seen a couple of years ago was some legislation within the Inflation Reduction Act, which you may have heard, that did a redesign in Part D, and it brought some new policies and some things that we're hoping will be really beneficial to our to folks who are transitioning into Medicare, or if you've already been in Medicare. Um, and so I'm going to go through very quickly because I want to get to the experts that we have here. But overall, in Medicare now, in 2025, there's going to be a standard annual deductible of $590. And what that means is you'll have to pay the first $590 of your prescription drug costs each year before your coverage kicks in. And then you'll move into what's known as the initial coverage phase. And so during that phase, you'll end up paying 25% of the cost of your drugs or your prescription drugs until you reach what is now a new annual out-of-pocket limit of $2,000. So just a reminder, that means you'll still have some cost sharing responsibility even after you paid your annual deductible. And then the third coverage phase in Medicare is what's called the catastrophic phase. And that's where we're going to get into what this new out-of-pocket cap, this $2,000 out-of-pocket cap means. But generally speaking, once you get into the catastrophic phase, your insurance plan and Medicare will be picking up the cost of those drugs. If we wanted to go a little bit into the history of Medicare previously, folks would have been paying 5% coinsurance during that catastrophic phase. So that change in particular is something that the MPF and many, many other organizations have been advocating for years, really since the inception of the Part D program. And we're excited to share some of those different policies as well. Moving forward, with the redesign, I think we'll cover briefly, some of the impacts to how the Part D program has been redesigned and what that might mean as it relates to different formulary coverage, right? So what's available, what might not be available, as well as some of the potential policies or utilization management techniques like, prior authorization, step therapy, some quantity limits. Just how might that impact the program as we adjust to these new changes and the entire program adjusts? There also is, and we'll get into this again, what has been dubbed you'll see this Medicare prescription payment plan. So that's within Part D. And the point of that program is to come together with the out-of-pocket cap I referenced earlier to allow an individual to spread those costs over the course of the year. So rather than have to, say, pay the $2,000 right up front, you can spread it out over those 10, 12 months, and we'll get into what that looks like. It's a little complicated, but it's also a policy that the NPF advocated for as that bill was coming together, really just to allow individuals to plan better and be able to spread different costs across the year. Also wanted to just flag and highlight the Extra Help program within Medicare, Part D Extra Help. It helps folks with limited income and resources cut some of those Part D costs. The Extra Help program can help you with the cost of your prescription drugs like deductibles and copays, and you can apply for Extra Help anytime before or after you enroll in Part D. That includes what is labeled here as QBM, which is a qualified Medicare beneficiary. It's a cost assistance program designed to help individuals who are eligible for both Medicare and Medicaid, which is known as dual eligibility. And there's different requirements for sort of how you might qualify for that, but wanted to flag that as well. And then just one final reminder that I think for many folks has been a surprise as they've transitioned into Medicare, but under a federal anti-kickback law, it is illegal for manufacturers, drug manufacturers otherwise, to offer any type of payment that might persuade an individual to purchase something that federal healthcare program like Medicare or Medicaid might pay for. So a lot of folks we know use copay assistance cards when you're in the commercial market before Medicare, and that helps to obviously afford those treatments. When you get into Medicare, those cards cannot be used in Medicare. So that's just always a thing that I think has been a surprise to some folks, but we want to make sure everyone knows that. So let's get into the conversation. I'll invite Dave and Dr. Hahn to come off camera if they're both there already. All right. Okay. So both of you, thank you so much for joining us. Before we get into some of the changes within the program that I do want to get into, I do for a second just want us to take a step back and really reflect on the Part D program in general. So, created in 2003 by Congress, and it was implemented in 2006. Um, so it's a little bit less than 20 years old. Still, I think relatively, I'm not going to call it a baby, but I think it's still a relatively new program in the grand scheme of how we've done things. And so I would love to get your thoughts just generally on what you've seen since it's been started and kind of where up until where we are about today. And Dave, would love to come to you first for that.
Sure. Well, thanks for the opportunity to address the NPF. I think this is a fantastic forum you have here. As far as the Part C and Part D benefits, this 2025 plan year that's coming up probably is the biggest significant change since the inception of the program with that very first year of 2006, the first year of coverage. And the way we've reduced, well, the way the government has reduced that out-of-pocket cap down to 2,000, because those folks who have Medicare benefits today are paying up to $8,000 for their out-of-pocket cap. And dropping from 8,000 to 2 is phenomenal, especially when many people are taking the specialty meds to cover their needs. So I think that's a very big deal. The other piece is with all of the changes taking place right now, you probably have noticed if anyone has looked at their plan options for 2025, there is a significant reduction in the number of carriers offering plans, the number of plans being offered by the carriers, which meant many of you who are participating today and your buddies, your family, have received annual notice of change letters spelling out a lot of the changes that are taking place and higher premiums, or they've received a lot of that said their plan's being canceled and they're just thrown for a loop and they're looking for advice. And we're here to help today, as well as the 1-800-Medicare and Medicare.com and brokers across the nation are all there to be advocates to help people find the right benefit, the right plan design for them this coming season.
Thanks, Dave. Dr. Hahn, any other insights? I mean, if you can think back to as you started seeing folks in Medicare up until today, would love to hear your perspective as well.
Yeah, I mean, the Medicare program is a little confusing for all of us, I would say. You know, when thinking about the patients coming in to see us, a lot of times it's tough to kind of figure out how to talk to somebody who's been on a stable medication for a long time, used to, a certain pattern. They're used to getting the coupon benefits you mentioned, so they're not really paying out of pocket. And then hitting Medicare and figuring out, hey, the medication that I am getting is approved, and that's great news. And it's like, yay. And then they get the bill for the medication and they're like, well, where's this coming from, right? And so what's interesting to me is that I only knew this because I had one commercially insured patient who the specialty pharmacy forgot to apply the coupon. And he came back and he said, I'm doing great, but this medicine was like $2,000. I mean, that's a little expensive for me. And I told him, I've never heard of that. You're not supposed to pay hardly anything usually for the coupon programs. We found out, we actually ended up getting him reimbursed. But it kind of led me to understand the whole system where these copays are out there. But it's almost like monopoly money because for most insurance, certainly for commercial insurances, they never see that cost because the coupon automatically wipes it out. And then when you get to Medicare, it's like even when the medication is covered, I've had patients come in with bills of $2,700 for one dose of a medication. And that's just not really sustainable for our elderly people on fixed incomes who are the most vulnerable, who need the most help. So I think certainly the cap is a welcome addition to the overall system that we have. But I'm really interested to see some of those asterisks by it, like you mentioned before, like how that's going to affect the step therapy, the formularies, because that's another piece that we've had struggles with. When we get a medication approved for certain patients, especially you think about some of the topical medicines, some of these medications come in relatively small tubes that people run out of within a week. And then the problem is their plan doesn't pay for another tube until the next month. So they end up treating their psoriasis for a week, and then things get a little better, and then it gets worse for 3 weeks, and then they get doled out that next kind of prescription. So we often have to tailor like these different exotic ways and throw multiple different medications at them. But why do we have to play these games? It's kind of silly. We should really just have a system that takes into account more flexibility for what patients need.
Absolutely. And, I think I'm not going to just say healthcare is complicated, but the system we're all operating in, and that's why, we're really fortunate, right, to have the perspective of you, Dr. Hahn, and Dave, all of the wealth of knowledge you brought or you're bringing to the table in terms of the perspective of how we go about thinking it. How can we manage costs for everyone? How can we make sure everyone in a perfect world gets to, that proper care that they need? And there's a lot of downward pressures in a ton of different areas, and that's a huge part of why the Medicare Part D program has been redesigned, was to bring some relief to folks. And so if we get into some of the specifics, and Dave, this is where I'm really excited to be able to chat with you. As we mentioned before, complex issues, let's try and make them simple. So we'll hear about the $2,000 out-of-pocket cap I mentioned before. That's in the catastrophic phase, so at the end. But does that cost of all the does the cost of all prescription drugs count towards that $2,000 out-of-pocket cap?
That's one of the most confusing questions that people have, is that not every medication applies towards that $2,000 threshold. It's only the drugs that are Part D approved drugs and are part of the plan's formulary. And every carrier has its own formulary. And even within the carrier, they might offer 3 different PDPs or prescription drug plans or MAPDs. And those formularies are different from plan to plan to plan. So while a drug might be covered on one formulary, it might not be covered on a different one. So if it's not covered, it does not apply towards that $2,000 out-of-pocket cap. So a person will have to pay the full retail cost unless they have some kind of GoodRx type discount. But typically, they're going to be paying a lot more than $2,000. The great news is this is the shopping season, and a person can use the plan comparison tools that brokers have access to, or Medicare.com has Medicare.gov has the access to the plan comparison tool. A person can enter in the medications they take. It will show the plan information for every plan offered within that person's county or state, depending if it's an MAPD or PDP. And it will show the annualized estimated cost based on the medications the person enters in there. And if a drug is not covered on one formulary, it might show tens and tens of thousands of dollars for the annual estimate. While another plan, it won't be more than $2,000 because the medication is actually covered there. So again, plan by plan by plan is different, and we're always encouraging every Medicare beneficiary to do the analysis every year.
Absolutely. You hit on such important points, which is why we're having this conversation today. Which, as folks are thinking about, completing their enrollment, which by the way ends December 7th, so exactly a month from today, the importance of really being able to review what are the things you need, are they covered in what you're looking at? And I'm not saying that, as we just laid out, there are resources to help you out. It still gets a little confusing, I would probably say. And Dr. Hahn, we were talking earlier last week, and you were mentioning, a personal experience that you've had as you've been trying to help, believe it's your parents as they look at Medicare. Would love to hear you there.
Yeah, I mean, I have been taking a personal deep dive into this Medicare comparison tool and all these plan documents. And I mean, the truth is, I don't know how an average person can navigate this. It's just so complex, and there's so much out there. You move to a different zip code, the number of plans available to you can double or halve. I mean, it's just really complicated. And so, yes, my parents are retiring, and they're trying to figure out to keep their plan now that they have through a state government versus going on Medicare. Then they were talking about this alphabet soup of Medicare Plan G, and then the Part D supplements, and then looking at the pricing of the Part D supplements, that it's not fixed, that things might change over time. So, those are some of the things we were thinking about. But what I realized when you're looking at especially the Medicare comparison tool is that it gives you a rather superficial look. I mean, it gives you some details. But I think what's really challenging for a lot of people is that when there are plans, for example, offered by one company that have different flavors, right? The standard plan, the gold or elite, the higher level plan versus the value plan. And some of these value plans have the reimbursement for the, the Medicare out-of-pocket fees that they'll actually give you back some of the money that you pay for Medicare. What becomes very confusing is that based on the information you get, just the top level information, the plans look basically the same. And I think that's some of the challenges that we have is that when people are just looking at it, some of those plans look really attractive and you could plug in your medicines, but what you don't know is what you might need later. One of the questions is you don't really know the details, as Dave mentioned, of those different prescription drug plans among those different flavors. But the other thing is, even when something's on a formulary, it doesn't tell you necessarily how hard it is to get that medication, because what we've seen oftentimes, this is not just Medicare, this is any insurance plan, is that something may be on the formulary, and then when you look up the formula, it says prior authorization required, but it doesn't tell you, for example, that they want you to fail like 3 or 4 different things. And then so what we've had to deal with often as providers, as physicians, is that we have a medication that we think makes sense for a patient, and we have our medical reasons for either jumping to the medication or saying we've tried 2 of the 4 options and the other options don't really make sense. I've had to write letters saying that, for example, the other medication on your formulary is actually less effective than the one they've tried already. So why would you make me take a step back in order to get the more effective medication, right? Just kind of general, really broad brushstrokes kind of explanation. But I think what ends up happening is that eventually I find, usually because we have our medical reasons. Eventually, we can probably get to the right person, write the right letter to get that through. But sometimes I can tell you, I recall not long ago spending hours on just getting one patient's medication covered. And we, as physicians and healthcare practitioners and offices, just don't have that kind of time to fight these fights for every single person. So I think that's where a lot of frustration sets in, a lot of confusion is that these really fine level details are a little harder to find and take a lot more time to really figure out and drill down into.
Thanks for that. And I know like many of us, whether you're someone living with psoriasis who's listening to this or is on with us right now, or you're trying to help a family member take a look at what are the options in Medicare. I think we always think of this as it's a team effort and it's a family effort, or it's close friends trying to help understand what's the best route to go. And so, Dave, kind of building off of that, first, if you have any other thoughts sort of to what Dr. Hahn was just speaking about, would love those. But would love if you could also take us through like even like, right, what do some of those different plans look like, or a silver or a value, like what does that mean?
Yes, Dr. Hahn packed so much information into 4 minutes, I got to tell you. And I want to speak a bit because we need to separate, in my mind, we need to separate the Medicare Advantage plans versus the standalone PDPs that people often supplement with a Medicare supplement plan, also called a Medigap policy. So in the Medicare Advantage plan, yes, it does include things like dental, vision, hearing, and a host of other supplemental benefits, and drug benefits are in there. And when you use the plan comparison tools, you're going to see an annual estimate for that entire bundle of services. And in that model, you can put in how many times you visit a primary care physician and how many specialist visits you have. And it's going to give you an estimate for that cost because each one of those things costs differently on a per visit type basis. But it will still do the formulary review the same way as the individual PDP does, where it's going to say whether the drug is covered or not, and which tier in the formulary it's going to be charged at. And most of the time, these plans have I'll say a low copay for a tier 1 or tier 2 medication. Those are generics. Tiers 3 is usually a preferred brand drug that often is usually a low percentage or a higher fixed copay, while tier 4 is usually almost always a co-insurance, so it's a percent of the drug cost, and tier 5 is typically a specialty tier, and that's almost always a percentage of the drug cost. And what we do is we have these plan comparison tools that make a good reference for us at that point in time. What we're not going to know as our meds change throughout the year, oh, does that mean I can switch to a different plan? No, you're locked in. Whether it's a PDP or Medicare Advantage plan, you're locked in for that calendar year, unless you qualify for a special enrollment period. Maybe you're moving to a different county or different state where the coverage is no longer available, so you have to switch over. Or there's a whole host of reasons for it, but typically most people don't qualify just because you get a new medication. So I bring that up because it's that these plan comparison tools help a consumer make the best decision they can at that point in time. We often coach brokers to say, have you spoken to your physicians, your medical team? Have they told you that you might be needing certain medications later in the year? And so we try to have people build that into the plan comparisons tool. So maybe they're just saying, I need 6 months worth of this medication, because that kind of factors it in for later in the year. So again, we're trying to make people feel comfortable with their decisions, but it truly is a complex benefit design, whether it's the PDP or the MAPD. But what I do want to kind of talk about is that $2,000 out-of-pocket cap right now, because it's not as simple as saying, oh, look, I spent $2,000. Because Medicare is doing behind-the-scenes math of how they can calculate to help standardize the way each plan offers its benefits. So we like to say, at most, you'll pay $2,000 for Part D covered drugs that are on your formulary. There's a great chance in the Medicare Advantage world, if you don't have a deductible, that you might be paying less than $1,000. But Medicare will be doing behind the scenes math that says you actually reached 2,000. So fantastic for that member. On the PDP side, same type of story. I've been doing analyses now since October 1st when the plan tool became available to us. And in most situations, a person is not paying the full $2,000 out of their own pocket, but Medicare will have thought they did. And again, there's no way to really know when you're there, but at one point, the pharmacist is going to say, yep, stop paying me. My computer system here shows that you've reached your max. Fantastic. And that's, I think, an important thing for people to realize, especially when you're buying expensive medicines like Skyrizi and Stelara and things that are really typically high coinsurance type products.
Thank you for that. And well, Dr. On, if you have anything, we want this to be conversational, so feel free to hop in too. But I got a lot of questions, so.
Yeah, I mean, it's really interesting because, I could see certainly, I know that some of the plans, for example, you'll have a 0 out-of-pocket copay for tier 1 and 2. So I presume on the back end, the plan is actually kicking in a little extra to get you down to that 0. So behind the scenes, the Medicare coverage plus what you pay, there might be a gap. So does that explain that kind of little gap or situations like that?
Yeah, there's all different ways that the formulary pricing is determined, whether it's the price negotiation that the prescription benefit management company has done on behalf of the insurance company, whether it's a reduction, a discount that the carrier wants to build in itself, because they know that these people are who take these types of medications consistently are much better risk for us. They don't have as much medical spend. So let's make sure they take those generic drugs and charge them nothing for it. Because if they didn't take those medications, if they couldn't afford those medications, odds are they're going to be needing more medical care. So it's a trade-off that the insurance company has, especially the Medicare Advantage plans that cover both the medical and the drug benefit.
Right. That certainly makes sense. You want people to take their antihypertensive or, they're going to have more ER visits. So it kind of makes sense. And one question I had for you is, we know that you look up your physician, for example, and you kind of can look up whether they're part of the network or not. But some of the studies that I've read have actually showed that some of those directories are not necessarily the most accurate. So is that something you've seen? Do you recommend actually calling your doctors and making sure they take these plans, or rather than just trusting the website?
Well, that has been, we call it the provider directory, right? Is one of the most difficult things to keep up to date by the day, because there are tens of thousands of doctors in network across the nation for any carrier. Like just think CIGNA, United Health, Humana, the big players all have a national footprint. we need to make sure that all those doctors, all those caregivers are listed there properly. So people fall out, they join back in because they negotiate their contracts with the insurance company. It's a long way to really say they are as accurate as can be on any given day. It's great to confirm with your caregiver to make sure that you truly are in this plan for 2025, because sometimes they are this year in 24, but they're not going to be next year. So as long as you get that confirmation from the actual provider, you're probably going to be in great shape. Yes, we do get lots of calls at the insurance companies directly from prospective members saying, can you please confirm that Dr. Kline is going to be in the network this year? And they'll be referencing every tool they have to help confirm that. But again, those are updated all the time.
Thank you. Thank you both. I want to keep us moving into something that I referenced earlier, which is called the Medicare Prescription Payment Plan. This is something that, again, was a part of the legislative change that is now law within the Inflation Reduction Act. And Dave, I think, my recollection as we were here in DC and there were different policies being, advocated for to be included in the legislation, a lot of folks started to call it smoothing. But what I want to just continue to reference is that what folks are going to see is that it is called the Medicare Prescription Payment Plan. And the point of it is to allow individuals to smooth those costs over 12 months. But can you give me what is it? What are we really looking at here? And then I got some other questions too, but I think you know where I'm going.
I sure do, and I hope you're all sitting down for this one. So this benefit is truly great if a person cannot afford their medication all at once. Because you're able to spread the cost of the drug over the remaining months of the calendar year. So if you join this program in January, you have 12 months to pay off that medication. There's no fee to join, there's no interest accrued to it. You're just able to pay it off in 12 installments. If you join this program in July, well, you have 7 months to pay it off. That's how that kind of works there, or maybe it's 6 months. Anyway, my point is that this is a program that any member for MAPD or PDP must opt into. It is not guaranteed enrollment for anyone automatically. You have to opt in. So how do you opt in? You have to call or contact your MAPD or PDP carrier and say, I want to opt into the Medicare Prescription Payment Plan program. And
just very quickly, just say out loud the MAPD and the PDP just for our audience.
Okay, great. So wait, what was that again?
Just take those acronyms and just explain.
Oh, I'm sorry. So the PDP is a prescription drug plan, the PDP, and the MAPD is a Medicare Advantage with prescription drug. So that's those two different buckets, or Part C and Part D. Okay, so here we are saying that if you have coverage with one of these two programs, you need to opt in proactively. You must contact your carrier to do that. When can you do it? Now. Now is a great time to do it. The program begins the first of the year. You can also do it later in the year, in 2025. But if you enroll or opt into it in calendar year 2024, you'll be able to have it approved for that first of the year. If you opt into this in 2025, CMS Medicare requires the plans to activate you within 24 hours, which means you might be at the pharmacy and you want to be in the program right then and there, but you won't be yet. You need to wait that full day until the carrier can actually get you in this system properly to reflect what happens. And why is this? Because if you have opted into the Medicare Prescription Payment Plan, you no longer pay the pharmacist for your medications. Your carrier, your insurance company, will pay the pharmacist, and the insurance company will send you a monthly bill. And you will have to pay that monthly bill for the cost of the drugs for whatever is left in the year, divided by that number of months. Okay, we'll just make it easier. The $2,000 all in January divided by 12 months, and it kind of works its way that way. But there's some nuances to it. But the point is, you get a bill, but you also get a bill for your premium, and you'll need to pay both bills. We're concerned that some people might pay just their premium, or they might pay just their payment program for their meds, and there might be some confusion there. So I know in our company, we're making sure we're looking to see if people are forgetting to pay one, and we'll do outreach to remind them because it's a new benefit for them. And then there's lots of questions about how they can pay for it. Can they use a credit card? Can they send a check in? All those ways a person can pay their monthly premium can be used for the payment for the Medicare prescription payment plan, except deducting from a Social Security or railroad account. Because it changes every month, that can't be established. People can opt in, they can opt out if they don't like it during the year. But here's the big thing I think people need to really understand. If you opt in for it, you're all in. You can't say, I want to opt in for my expensive drug, but I want to pay upfront, at time of service for all my little $5 copay drugs. They're saying, no, it's all your medication goes into this bucket. So Medicare has said, this is a really good program. You might be a likely candidate if you know you're going to be spending $2,000, and then you can spread it over the course of the year. Or if you just have a high cost medication you can't afford all at once. But if you're taking just low price generics, and you're then going to spread that over the course of the year, towards the end of the year, you're going to be paying a lot more than the cost of that drug was just at that point of sale. So again, if you are going to spend a lot of money on a drug, let's say over $600, or if you're going to reach over $2,000, it might make sense to join this if you can't pay for the drug all at once. And when you want to opt in, the best thing is the person who answers the phone there on that specialist team for that Medicare prescription payment plan, they're trained in all these things to explain it to you nice and slowly. Not like I'm trying to rush right now in a time-constrained town hall. But there's a lot of pieces to it. But we're saying this could be very helpful for some people who know they're going to reach 2,000. But if you're not going to reach 2,000, this might not be the right plan for you. If you can pay for the drugs out of your pocket each month, this wouldn't be the right kind of plan for you. And if you get extra help from the government, this is not the right kind of plan for you, because you have other benefits with extra help that are much different and probably stronger than the smoothing program that Medicare has set up. So lots of information there. Sorry, Jason, but hope it was somewhat helpful.
That was awesome. And just to reiterate, and Dr. Ahn would love to get your thoughts, even, sitting in your chair, I think it'd be interesting to hear, how much did you know about this? How do you think about this when maybe someone comes in? Is this something that maybe even have time to discuss? And then Dave, just to reiterate, it's an opt-in program. You gotta opt in. You can join at any time during the year, but you have to be cognizant sort of what that timeline will look like, whether it's 12 months or 6 months. And then before I get to Dr. Ahn, Dave, tell me something. If I opted in, I got a bill and I just pay my premium, I don't even realize that this other thing is also a bill, and say I miss it, what happens then?
Yeah, that's a great question. If people fail to pay their monthly installment of their Medicare prescription payment plan program, they will receive another bill. And there's a 60-day grace period before a person is terminated from that program. They're not kicked out of their Medicare Advantage plan or their prescription drug plan. They just will no longer have the benefit of having the drugs smoothed over the course of the year. They're going to get a new bill from the carrier that's going to be for the full amount owed. And when they go to the pharmacy next to pick up their next month's worth of medication, they'll have to pay the pharmacist right then and there for it. But they will receive, these people who fail to pay timely will receive notices from the carriers reminding them to pay. Again, they'll get another note next month. But there is no interest charge if they don't pay it. They're not kicked out of their drug benefit. They just are removed from this opt-in program of smoothing their drug costs.
Perfect. Thank you. I appreciate that. And, all of these things are new. I think I want to reiterate that, right? And CMS did have to kind of turn this around and start to implement it quickly. And I think it's a real challenge to do that when you take such a big system and try to readjust and redesign how you're doing it. And so, this is the first year in it. And one thing I would highlight to our listeners and to folks is, if you're having an experience, whether it's good, bad, or, in between, we'll be in touch. We want to learn more about what your experience has been so that we can help make this program better, right? That's the goal of all of us, is to make, getting care, getting the right care, making it easier for folks like Dr. Hahn to be able to provide care. And that's right. That's the goal. That's why we're all here. Of course, there are challenges that are going to happen, and there's, in our community, we know there are a lot of different treatments available, whether they're systemic, whether they're topicals, whether it's just finding the right physician. And so, in a lot of ways, I think a lot of things happen to our community first in terms of what that looks like. But I'll stop there. Dr. Hahn, any thoughts on what this Medicare prescription payment plan might mean, or, would love to get your opinion.
Yeah, I mean, on first glance, it sounds great. And I don't want to sound like a pessimist here. I'm a medical scientist, so I am taught to question everything. As Dave was talking, I was just thinking about the scenario where, this person is terminated from the smoothing or the payment plan, and then the next bill they get at the pharmacy, let's say they pay the whole 2,000 or whatever, let's just say they meet their cap. What happens to those outstanding bills? I'd imagine there probably is some way for the insurance company to square up with Medicare, but these systems are made for creative people to break. So it'll be interesting to see those situations, but I'd imagine there are probably some situations that they've thought of that they'll have solutions for. But what I'm really more interested in, honestly, is to see where this all shakes out, because as we know, most of these programs that are government programs are meant to be budget neutral at the end of the day. So whatever benefit you're giving, reducing their out-of-pocket payments from, we said before, like $8,000 and up in plans before to now $2,000, where's that money coming out of? And for us in psoriasis, especially as we're dealing with the advent of biosimilars and medications that really change the game in terms of drug costs, like how is that going to really play into what we have access to? And I alluded to that earlier because, for example, we're talking about medications that are biosimilars now. So we have medications like adalimumab and ustekinumab that now have or are coming out with more and more biosimilars. And these are medications that are 20 years old, 15 years old. So these are by no means the latest and greatest medications we have for psoriasis. So it's going to be kind of interesting to me to see when we have our patients coming in who are on an advanced medication. And just to give you a ballpark, for example, some of our newer medications have a 100% clearance rate of above 70%. So the psoriasis patient walks in my door, and I can tell that person confidently that over time, about 3/4 of my patients get completely clear. That number for those older medications that have the biosimilars is in the 20 to 25% range. So we're talking about a pretty big difference in terms of efficacy. So when we have a patient coming in who's used to getting this other medication, and they think this is great, I'm not going to have to pay as much anymore out of pocket for it, but then you realize maybe that medicine is now no longer on the formulary, and then we have to try this, or maybe it's a kind of prior authorization where they won't let you try it until you do the other medication. It's going to be kind of interesting to see how those gymnastics play out in terms of just managing the medications. And again, writing the letters, trying to advocate for our patients, but with limited time and resources.
I think that will always be the case, Dr. Hahn, where whether it's a commercial plan or Medicare plan, the clinical teams are always trying to identify which patients need to have the step therapy accelerated, which ones are able and need to have their formulary exceptions approved. And it's a case-by-case basis. Every insurance company out here has a very competent scientific team that's reviewing case by case by case the types of letters that you and your colleagues send in. There are how many millions of people in the Medicare benefits, and they're all trying to take the medications that best meet their needs. Yet every carrier has its own restricted formulary. And that's why, we're grateful that the enrollment season is 54 days and not just a month. But unfortunately, a person can't switch during the year if they are prescribed a new medication that has a very good clearance rate. But we always say, please, everyone should use that plan comparison tool now and talk to their prescribers to see, is there a likelihood that I might be needing to take something else later, and to run a scenario if that drug is included in the formulary or not.
So yeah, I mean that's interesting, and I have maybe a little bit of a story and then a question at the end for you because it's interesting as we're talking this through. I'm just recounting all the times I've had to call into insurance companies, and this is regardless of what type of insurance. There's always some hoops to jump through, right? And I would say on average, I spend probably a good 20 minutes talking to multiple people before I end up getting to the right person. Because this is always the frustration. We call the main line for the plan, and then we get to a person. They said, well, this is lives in the specialty world. I get to the next person. The next person in the specialty world says, this is a carve out that's in a different department. And I'm very used to actually talking to 4 or 5 people before I get to the right person. And then the frustration for me becomes then we get through this process. I try to explain myself, and then I get a call back. They set up a call back, and I get a call back from a pharmacist, not a clinician, and I'm trying to explain, the reasons behind, for example, we had a patient who I wanted to put on a medication, and they said they have to go through this other medicine. And it was just the example I gave earlier, kind of that, I mentioned this other medication, the efficacy is lower. They already are suffering, having breakthrough joint disease on this medication that should be more effective than the one you're asking me to go to. I'm asking for this other medication that works better, and we think it's the right medication for the patient. But because it's a clinical pharmacist that insurance company put into this role, they actually weren't even able to do anything. So, all of this is to say, these fine details have a great impact on what you feel as your access to medications. And so what I've noticed is, for example, on the Medicare, the comparison tool, there's those star ratings. Like, do you put any stock into that because I know they aggregated a lot of data from people, just their, happiness and engagement with customer service and things. Does that matter? Like, what kind of other resources do we have aside from asking friends and asking people, asking around, to really try to figure out which companies and which plans are easier to deal with?
Yeah, let me bifurcate your comments. The first part is the team members that you would speak to trying to get the exceptions approved. The insurance companies have different models. Some might have pharmacists be that front line, almost like a step therapy, right? Where you meet with the pharmacist first, and then eventually you reach with a clinician. And so I can't speak to any norm across all carriers to that. But I do know that I know that these insurance carriers take it very seriously, because we don't view anyone to be a member ID number. We view these all to be, and this is how we coach people. This is our parent, our grandparent, our aunt, our uncle, who we're talking to. Let's make sure that we are treating them with the dignity and the care that we would want for our parents, our grandparents, our aunts, our uncles. And if you ever have an encounter where that's not happening, it's because the last call probably triggered them off on something. But they're all trying to say, I care about this caller, and they're trying to do what's right. So there's that piece. But I think that just paraphrase your second part of that issue for me, Dr. Hahn, please. The last question you had for me.
Yeah, which is really, in determining how easy or difficult it is to get things covered on a plan, because that's always the fine print, right? Is we'll cover this amount of covered benefits, but you don't necessarily know, for example, when you need some imaging, what the
Yeah.
criteria are that company puts forth for imaging, and they might say that your doctor's reason doesn't really make sense, and we require you to do like an ultrasound before an MRI, things like that. So, like, what are some kind of clues people can have that tell, like, do those star ratings really help? Are they based on, good data?
Yeah, that was the star ratings component, and this does lead together. Um, the carriers do invest a lot of resources to get their stars high. Why? It's a financial incentive. Medicare will give bonuses to plans if they're 5 stars, 4.5 stars, 4, 3.5, just based on how many stars you get more money to help offset, and then the carriers don't take it to the bottom line. We're not allowed to. It gets invested into the benefits themselves. We're able to offer meals when you leave a hospital for 30 days because we have extra money available to us because we have high star ratings. So it is important for the insurance companies to get as high of a star rating as they can in each one of the different measures that are out there. And there are dozens of measures. The Medicare Advantage measures are different than the prescription drug plan measures because the PDPs don't have medical components to it, right? So they're a bit different there. And what Medicare often does is, okay, good, everyone is now the carriers are now at a pretty good threshold. So we're going to remove some star ratings and add new parameters. We're introducing new things that we're going to start measuring going forward. So you're going to find plans that might be 2.5 stars. So, I wouldn't want to stay at a 2.5-star hotel. But the point is, if you drill down to see what components of that overall 2.5-star really help drive it down, you might say, oh, it was medication therapy management, the MTM program that sunk it. So maybe a person won't want to be in that kind of a plan. But I've always viewed it this way. If a plan is soft in a star rating, you know that they're investing a lot of people and money in to get that one up real fast. So you're going to have a quick reversal and focus by the leadership and the management as they develop their stars.
Appreciate. So we got about 8 minutes left. I want to hit on one final topic, and it's clear that who knows, maybe we'll be back here again. This could probably go on for hours, right? And just some of these topics we've went through. You know, Dave, we were talking a little bit before, and I think you referenced it in terms of in addition to the cap and the Medicare prescription payment plan and what we've talked about, Medicare obviously this August released the negotiations with manufacturers for the first 10 treatments that the law authorized them in this process to go ahead and negotiate drug prices. I'm going to give you a kind of a perspective that, at least from the NPF, you know, number one, just to be really clear, our mission, right? It's to help people right now, right? More affordable treatments, better access, higher quality care, all the likes, of course, as we drive towards a cure. And I think when a lot of people hear negotiated prices, right, it's like, okay, lower drug prices, all of that. I think from our perspective, it's going to be really interesting to track this. And side note, negotiations, those negotiated prices on those 10 treatments, obviously those are not all in psoriasis. 2 of the 10 are relevant to our community. They'll go into effect in 2026. So this is not a next year thing. Just want to be really clear for everyone. It's not next year. But I'm curious what's going to happen. What is the impact of these prices going to be, on access to those actual treatments that have been negotiated on? What might the impact be as a spillover effect to other treatments, maybe in the same class or just in general? And then because of how we've done this redesign, right? And Dr. Hans hit on this a little bit, and this is not, you know, I'm not coming at you as the big bad, you know, person. It's just that there are different now cost pressures, right? Different streams in terms of how we manage costs or how the program is going to manage costs. And so does that mean we might have, you know, some more steps like, and I know you might not be able to get into everything, but what are your thoughts as you reflect on what's been and now what will be?
Yeah, I guess I'll take this first, Dr. Han. The inclusion of these negotiated 10 medications is great news for the Medicare beneficiary. It doesn't happen until 2026. We were already working on our plan designs for 2026, even though we're still selling for 2025. And so we're there. We do know what kind of discount that Medicare has negotiated. For Enbrel and Stelara, it's about 67 or 66% price discount. That's great news when you think how expensive those 2 medications are. Now, what does that mean as we actually implement it? Well, many folks who have Medicare benefits know that we have that 5-tier or 6-tier formulary. And perhaps these medications will no longer be part of the specialty tier. They might become the preferred brand tier, which is tier 3 medication, which is usually like a $50, I'm rounding, right? $50 copay, or maybe a 20% coinsurance. Well, that sure is better than the specialty rate that's going to be a 25 to 40% coinsurance against a really high drug cost. So we're going to see every carrier place that medication at a different tier based on what they are going to do for their own plan benefit design. I can't say it's going to be tier 3 for everyone. I can't say it'll be tier 4, but I do think that this is what all of our formulary clinical teams are analyzing today. I see it on our CIGNA business because I'm on those calls, and I know that whatever we do, so are the other carriers. So in 2026, we'll be seeing some great benefit from these 10 negotiated drugs that will be introduced.
Dr. Hahn, any thoughts there? No, in terms of referencing, compare those versus, all maybe more novel treatments. I think like that's the debate that we're all having, right? Dave and Dr. Hahn, is like, what's this going to impact? And maybe those treatments, right, is maybe that's not going to be the right thing for everyone. Like that's where we land, and that's really what we want to understand. So Dr. Hahn, curious what your thoughts are.
I think, certainly it's a net plus because access is going to be good to these medications, and it's not like any of them are terrible. But at the same time, I often do wonder about the divergent pressures on our patients, right? And this came into, I think, real focus when for some of our commercial plans, I remember at one point the formulary for one of the companies changed, and my patient actually brought in a letter that they got saying that if they talked to their doctor and switched to a different psoriasis medicine, they would get a gift card for a certain amount of money to switch the medication. And so in our kind of world, we call this non-medical switching, where it's not because we decided the medicine isn't working, isn't right for you, or having side effect. It's just a non-medical reason. Formulary changed. And usually when formulary changes, we can get patients continued on medication they're doing well on, but we've seen more and more pushback on that. And the reason that scares me a little is because that gift card of, let's say, $500, for somebody who has a lot of money, a lot of income, they're going to say, hey, I don't want to play this game of switching around all these medications. That's not such a big deal to me. I'm going to stay on my medicine. But for somebody who's, just trying to get by living paycheck to paycheck, that's a lot of money. And so they're taking that and they're kind of take another medicine, which we don't know. They could have a side effect. They could have an allergy to that medicine. They could have issues with it, like their joints getting worse. So putting this kind of financial pressure on our patients almost kind of creates a backward incentive in some ways, that now you'll have people who can easily afford the 2,000, at least that's the cap, but they'll say, hey, give me the latest and greatest, the best medicine, specialty tier, I don't care. And our other patients who are kind of less financially well off are going to say, I need to save every dollar I can. Give me this kind of generic tier medication, biosimilar, whatever that's in there is. So I think, we have to be very thoughtful and careful about how we design our systems and what kind of pressures we're putting on our patients. And that's the part that concerns me a little bit. Even the best laid plans have some kind of unintended consequences. So again, an overall positive, but we're going to be kind of making sure that we keep an eye on how we can best serve our patients at the end of the day.
Jason, I know you're pressed for time because we're at the top of the hour, but I would with a 30-second closing comment here for folks just as they evaluate plans for this coming year. Never assume that the medication that's covered today will be covered next year. You really need to do that formulary review every enrollment season. Know that there's a premium you typically pay, and the premium does not apply towards that $2,000 cap. And that $2,000 cap is for Part D covered drugs, things that are on the formulary. So if you're buying things outside of that, you're going to be paying for that outside of that. Just want to make sure those points are there. But insurance brokers, insurance carriers, Medicare is all there to help folks in addition to NPF.
And real quick from me that, just to add that not everything has to come through a pharmacy benefit. We do have some psoriasis medications that actually come through on the medical benefit side too. There's also phototherapy that's durable medical equipment. So there are some other options, and I think it pays to really find somebody, as a dermatology specialist who is aware of these different ways that we can kind of navigate the landscape and try to figure out what the best path to get our patients on medication are, because there's more than one way to get these medications covered as well.
Well, number one, Dr. Hahn and Dave, thank you so much for joining us. This is going to be a really tremendous resource for our community as folks think about not just this year's open enrollment, but this will be a resource that survives in. I'm really grateful to both of you for being able to be here and share your perspective. And specifically, you know, I think, like I said before, we all have the same goal, right? Everyone who's working in healthcare and there's all these different kind of areas has the best intentions at mind, and sometimes things are challenging, but that's why I appreciate, Dave, you being here. I know it's not always let's put it this way. Appreciate you being here to chat and educate us on different perspectives, because that's the only way we're going to come to, you know, I think the best solution for all of us and for the end user, which is folks in our community in this case. So you see here the conclusion side. You want to make sure you sign up for Part D plan, do that research as we've reiterated all night long. You want to check to see if those medications are available. And make sure you get help if you need to, whether that's your family, whether that's a broker that, you know, Dave was talking about earlier. We have a patient navigation center here too, who can help direct you to certain resources. And open enrollment is going to be ending December 7th, 1 month from today. And we appreciate everyone who joined us tonight and those who are listening to this after the fact. And I think, Bev, am I all done for tonight now?
Yes, you are. Thank you, Jason. As Jason mentioned earlier, just wanted to highlight a few other resources that are available. We definitely want to thank our panel members for being here today and your ability to answer some of the questions that people may have. If we didn't answer all of your questions, please view our webinar, 2025 Medicare Changes and What They Mean for You, with Jason Mackey and Jason Harris. Or listen to our Soundbites podcast addressing the Medicare changes from the perspective of another physician who's a dermatologist and rheumatologist, Dr. Alice Gottlieb, and his moderator, Jason Harris. Other resources, if you're still looking for additional help, include our Medicare Resource Center, where you can learn more about Medicare Parts A, B, C, and D at psoriasis.org/Medicare-resources. You can view this town hall again and other past webinars on our Watch and Listen site. Again, at psoriasis.org/watch-and-listen. While there, listen to our podcast series, Sound Bites, to hear the latest about managing psoriasis and psoriatic arthritis from a variety of experts in the field of psoriatic disease. We even have a few episodes from Dr. Hahn. Thank you. If you have additional questions about psoriasis, psoriatic arthritis, and treatment options, or if you need help in finding a healthcare provider, contact our Patient Navigation Center by email or phone as indicated on the screen. And thank you, David and Dr. Hahn, for being here today. We really appreciate your time and efforts to answer the many questions we received and the discussion that you had. Your insights and expertise are also greatly appreciated. Thank you also to you who participated in today's town hall. We hope you found the information helpful as you work to complete your enrollment for Medicare. Please provide feedback on this town hall discussion by taking our short questionnaire via the link under the description on the webpage for this town hall at psoriasis.org/watch-and-listen. We'd love to hear what you think about the town hall and content. Your feedback will also help us identify how we can make events like today better. We value and appreciate your comments. This concludes our 2025 Medicare Changes Town Hall. Thank you for attending.
Thanks, everyone. Have a good night.